All right, so we'll start with this case. What do we got? Why don't you start?
There's multiple rib fractures.
And well, what do we always start with when we're reading chest radiograph?
Lines and tubes.
So what do you think?
So there's a left chest wall. Looks like it's going.
You can show. Yeah.
Left chest wall came up forward, and the tip is kind of kinked.
So what is the significance if you see that kind of appearance there?
Like you're concerned if it goes into like the azygos.
So when it hooks like that in this location, then you think about then we think about it moving into the azygos vein. And then on the lateral view, that confirms it. On the lateral view, you can see it's coursing posteriorly. So it's going into the azygos venous arch. So that's the appearance of a catheter going into the azygos vein. Is nicely confirmed on a CT scan. Okay? All right.
So we see left central line or catheter coursing the left thorax, basically. There's a right catheter as well, but the left one looks like it's coursing to the left. Thorax might be like persistent cava by chance, or not sure what it's, or actually no. It could actually be going through the one of the arteries of the arch and coursing down to the descending aorta.
So when you see a catheter and it's taking an abnormal course, if it's taking a course like this, so there are some possibilities. One, it might not be intravascular, right? So the first question you would ask is what?
If there's like in the thorax by chance, like is it going to the lung or is it going through?
Well, you would ask the team, if you see a catheter and it's taking an abnormal course, the first question you ask the team is what? Is there blood return? Right. So that's the first question. Is there blood return from the catheter? Okay. Secondly, what kind of blood? Because if you're worried if the catheter is going into a branch vessel and got into the aorta, right, then it would be what would be different about that blood as opposed to the blood that you would expect to get from a venous catheter?
Right.
It would be arterial blood, right? It would be arterial blood. The possibility is it could be in a left-sided superior vena cava. Okay, there is another possibility when a catheter takes an abnormal course like that might also give you arterial blood, arterial saturated blood. And what is that? Not for this particular case, but in some cases. Any thoughts? If they what? No. So if you see a catheter, it looks like it's taking an abnormal course, you ask them what kind of blood are you getting, and they say, oh, we're getting arterial blood. An anomalous pulmonary vein, right? You can have anomalous pulmonary venous return that returns to, let's say, the subclavian vein, and if it gets into an anomalous pulmonary vein, well, that blood is arterial blood, even though it's not under systemic arterial pressure. Okay, so for this particular case, that catheter coming down the left side, what's the answer? You don't see the catheter, but of course you always look at prior imaging on the patient to look at their anatomy. Yeah, so there's a persistent left superior vena cava. Where does a persistent left superior vena cava drain? Yes, persistent left superior vena cava drains to a dilated coronary sinus. So you can follow that all the way down, and it will drain into a dilated coronary sinus. So a catheter coming down the left side of the mediastinum, most often when it appears like that, you think of persistent left superior vena cava. So usually it looks something like this. It may communicate with the right superior vena cava. It may not. It may be the only superior vena cava. Sometimes there is no right superior vena cava and there's only a left superior vena cava. So that is a persistent left superior vena cava. And it will drain to a dilated coronary sinus. And this is pretty much, what they all look like. So this vessel that's posterior to this, here's the left superior vena cava. You'll see it as this abnormal vessel in the anterior mediastinum. What is this vessel posterior to that? What's this vessel here? Anybody? That's the left superior pulmonary vein. Okay, so you'll see two vessels here. One will be the persistent left superior vena cava. One will be the left superior pulmonary vein. Right, that you can follow it right here. You'll see that the left superior pulmonary vein is posterior to the left superior vena cava, right? And you can follow it going into the left atrium. Okay, so that is persistent left SVC. What's the abnormality on this chest radiograph?
It's like a right paratracheal opacity.
Yeah, so there's a right paratracheal rounded opacity. So in terms of differential, what might you start with? What could that be?
Like probably lymphadenopathy.
Yeah, so lymphadenopathy might be the first thing you think about, right? If you see a right paratracheal mass like that, okay? What else could it be? And in this case, given the topic of this lecture, what else might you consider?
Dilated azygos.
Yeah, so a dilated azygos vein, oval-shaped opacity in the right paratracheal region. What are the things that you think of that might give you a dilated azygos vein? What could give you a dilated azygos vein?
Like SVC syndrome.
So obstruction of the SVC, obstruction of the IVC, the azygos vein can act as a collateral. That can cause dilatation of the azygos vein. What else might give you dilatation of the azygos vein?
Continuation of IVC.
Azygos continuation of IVC. What else? Anything that elevates central venous pressure, congestive heart failure can do it. Anything in the pregnancy even, anything that elevates central venous pressure can give you a dilated azygos vein also. So those are some things that you might consider for a dilated azygos vein, okay? And in this case, the answer is, how do you recognize that? There's no intrahepatic IVC. There's this vessel posteriorly, which represents that azygos continuation, and it goes up. It goes all the way up to a dilated azygos arch that drains through superior vena cava. But the key is that there is no intrahepatic inferior vena cava. So where do the hepatic veins drain? Where do they go? They're the hepatic veins. Where are they going to go?
They come to the right atrium, or?
They do go up to the right atrium. They form a smaller IVC just before it joins the right atrium, right? But the IVC actually inside the liver itself, you're not going to see. So on an upright chest X-ray, there are some numbers here. Should not be greater than 1 centimeter. Supine, of course, it dilates, so there are numbers there too. So the azygos can get smaller with upright positioning, deep inspiration, Valsalva. Used to be an old question, how do you differentiate lymphadenopathy from dilated azygos vein on fluoroscopy? But of course, it's not something we need to worry about anymore. So these are some things that can cause dilatation of the azygos vein. Rare causes: constricted pericarditis, pericardial effusion, aneurysms of the azygos vein. But azygos continuation, that's kind of a favorite on exams for what might give you dilated azygos vein. So it will be dilated all the way up. The azygos venous arch is also dilated. Okay. So as we've said, the key is absence of the intrahepatic inferior vena cava in that case. If I just give you these images, you can tell me that this patient has azygos continuation of the IVC. So what's the key to looking at these images and telling me, oh, this is going to be azygos continuation?
The vein is like posterior to the renal vessels, renal artery.
Yeah, so this IVC. It's not really an IVC embryologically, but it's posterior to the renal artery. Usually IVC is anterior to the renal artery. When you have this, then this vessel has developed more posteriorly. This variant develops more posteriorly than normal, and that then gives you Azygos continuation of the inferior vena cava. And so you can follow that. You see it's back here. That's the Azygos continuation of the IVC. All right. That just has to do with the embryology of how these things form. So normally, the IVC is going to be the anterior to the right renal artery, but if you happen to notice on an abdominal CT that your IVC, or what you're calling the IVC, is posterior to the renal artery, suspect that you might have Azygos continuation of the inferior vena cava. Okay. What's wrong with this person?
There's an SVC thrombus.
Yeah, so what's the cause of the SVC thrombus, you think?
Is there like a central line?
Yeah, so it looks like there's a catheter here, right? Thrombus is formed around the catheter. So you can see the thrombus, but what's the first thing that strikes you as you're going through the images?
The collateral.
Yeah, you have all these bright collaterals, right? So these are bright collaterals because they contain undiluted contrast. So you're injecting contrast into an upper extremity. When it gets into all these collateral vessels, it's not diluted yet by the blood pool. And so that's why you will see all these collateral vessels. When you see that, suspect that there might be an area of central venous obstruction. So what you can do is widen the windows and look at vascular windows, and it can show you the different phases of the contrast, or contrast that is more dilute as opposed to this very dense undiluted contrast. And this can help you to follow the blood vessels to kind of localize where the obstruction might be. But whenever you see all of these collaterals in the mediastinum, think about central venous obstruction, and then look to make sure, at least try to make sure, that your central veins are okay. And in this particular case, we can see that there's that big thrombus along the left brachiocephalic vein extending into the superior vena cava. So as we follow it, see there's that thrombus there around the catheter going into the SVC. Okay, and so you'll have collateral roots. So the Azygos vein is a very important collateral root when you have SVC obstruction. So that can act as a collateral and help to keep portions of the superior vena cava open depending on where the obstruction is. So here's this big thrombus along the left brachiocephalic vein, and here's the Azygos vein kind of acting as a collateral root to keep the superior vena cava at least below the obstruction patent. All right. So let's talk about causes of SVC obstruction and what you might be looking for. All of it, I've given it to you. Some of these things in the handouts. So lung cancer and lymphadenopathy, very common. Whenever you see dense contrast, undiluted contrast within the Azygos vein, so collaterals in the chest wall, but especially when you see undiluted contrast like that in the Azygos vein, look very carefully at the central veins. Look to see if there's any evidence of obstruction here. The SVC is completely obstructed. In this particular case, is another bad case of lung cancer. You can see there's just complete obstruction of the superior vena cava, and also this encasement of the right pulmonary artery. Again, that dense contrast here within undiluted contrast within the Azygos vein. Depending on where the obstruction is, that alters the way the Azygos vein can function. If you have obstruction of the SVC above the Azygos arch, supraazygos obstruction of the SVC. So here the obstruction is above the level of the Azygos vein. Again, you can see the undiluted contrast there in the Azygos vein. So the Azygos then will carry blood to the SVC below the obstruction. So it helps to maintain patency of the superior vena cava below the obstruction. And then you can follow, you'll see the undiluted contrast going into the Azygos vein and then into the superior vena cava below the level of the obstruction. If there's infraazygos obstruction of the superior vena cava, if it's obstructed below the connection with the Azygos vein, then the Azygos vein will take the blood away from the superior vena cava above the obstruction, and then we'll try to collateralize it to the inferior vena cava. Okay, so that's how the azygos vein can function when you have SVC obstruction. And then you will see this dense undiluted contrast collateral vessels going into the inferior vena cava. Another clue, sometimes on abdominal CT scans, that you might have central venous obstruction is if you have enhancement around the falciform ligament within the liver. So if you see that, there can be collateral vessels that go into the liver, into the falciform ligament, veins of Sappi, and all that other stuff that can carry that undiluted contrast as collaterals and will give you these foci of enhancement around the liver. So if you see that on an abdominal CT, that might be a sign that you have obstruction of the central venous obstruction up higher. Here's an example where you have this focal area of enhancement like that in the liver. You can actually see these collateral vessels that are going in there. All these collaterals along the chest wall, they come down collateralized to these vessels around the portal vein. And then these can get into the liver, giving you these foci of abnormal enhancement within the liver, right? So these are other signs of central venous obstruction. Okay. This chest radiograph, what's abnormal here?
Delucency in the right lung.
Yeah, so this area here, there's an area when you compare symmetrically from one side to the other, we see that this area here looks more lucid, right? Now we've covered causes of hyperlucent lung before, but given that we're talking about vascular problems in this conference, what might give you that appearance?
PE,
What do we call this?
Westermark sign.
Okay, so this can be one rare cause of increased lucency or hyperlucent lung, could be decreased pulmonary blood flow. You can see that with this Westermark sign if you have PE, that causes it. Now so the vessels here, the vessels there might be thrombosed, right? But why does it look lucid? Why does it look like there are paucity of vessels there? Even if they have clot in it, they should still show up on the X-ray. Why does it look lucid? Yeah. So because you're not getting oxygen exchange, so the mechanism of the lung is to shunt the blood flow away from that area. So that will cause decreased perfusion to that area. And so that's why it can look more lucid on the chest radiograph, that they'll be shunting away from that area. All right. So here, what do we have here? There are actually two signs on this chest radiograph that you can talk about.
Like peripheral, like opacity.
Yeah, so the peripheral opacity, right? What might that represent?
It's like Hampton zone.
So it's an indication of what? So what is this? What would this represent then? What would the? Yeah. So Hampton's hump, right? So that might be an infarct, okay, especially if the patient's presenting with signs of pulmonary embolism. So plain film findings associated with pulmonary embolism. So one of them is the Westermark sign, Hampton's hump. It's a sign of infarction. What's the other sign demonstrated here? The Fleischner sign, right? What is that?
Like vascular congestion?
Well, prominence like enlargement of the pulmonary artery, enlargement of the ipsilateral pulmonary artery, right? So that's called Fleischner sign. So a PE is usually on CT of when we have an infarct, we see a wedge-shaped peripheral opacity, right? That's the classic description. Why is this Hampton's hump and not Hampton's corner? Why isn't it it's not a corner, it's a hump. It's rounded off. Why is that? Because you will have collaterals that can supply the proximal area of the infarct that can round off the corner. And so it's the more distal areas where you will see the consolidation in the infarct. So that tends to round off that medial portion of the infarct. That's why you don't get a corner, you get Hampton's hump and not Hampton's corner. All right, so consolidation and peripheral consolidation in somebody with pulmonary infarct. There are two possibilities actually when you have a peripheral consolidation like this in somebody with a pulmonary embolism. What are the two possibilities for the peripheral consolidation? You mentioned one, which is infarct. What's the second? Hemorrhage. How do you differentiate them? You really can't on the initial CT, you can't, but what happens on follow-ups? Well, the hemorrhage resolves faster. So the consolidation from hemorrhage resolves faster. The consolidation from the infarct resolves slower, and often, months later or weeks later, you will have a scar. Actually, there's a sign that's described for how a pulmonary infarct resolves as it kind of gets smaller and smaller from the periphery. Do you know what that sign is called? It's called the melting ice cube sign, the melting ice cube sign. So it kind of melts like an ice cube, right, if you happen to look at it on follow-up CT scans. Actually, there was a time when it was advised when you were doing PE scans to actually keep going down and scan the legs. You guys never heard of this, right? To actually scan the lower legs to look for clots, right? So I mean, I'm glad they decided to do away with this. The problem was they were finding clots in people who didn't have PEs and nobody knew what to do. So anyway, most cases, right, most emboli to the lungs arise from clots in the deep venous system of the extremities. So infarction can be a complication of pulmonary embolism. We talked about pulmonary hemorrhage, the differences between consolidations for pulmonary hemorrhage and pulmonary infarct. Sometimes you can have cavitation, right? If you have cavitation, of course, you think of septic emboli, but very large infarcts also can develop cavitation. That's called just aseptic necrosis in very large infarcts, but that's rather unusual. Usually, if you see peripheral opacities like that with cavitation, you're going to think about septic emboli. As we've said, in most cases with PE, the chest X-ray is normal. The findings that we've discussed, the Westermarck sign, the Fleischner sign, Hampton's hump, so all those things that we've already talked about for PE. The CT protocol, we like thin slices, contrast, how do you time it? Well, one is to just use a default of 20 seconds, but now it's better to use bolus tracking. GE calls it smart prep. You'll notice that when you're looking at a PE scan, many times that it's the first image, you can recognize, at least on the old scanner, on the old G scanner with the protocols that are set up there, you can recognize as soon as you open the study that it was a study for PE, because it starts at the bottom, and as you scroll through, it goes to the top, right? It goes from the bottom to the top. I don't think that's true now with the Alpha scanner. The protocol there, I think, goes from the top down. But why was that? Why is that? That the scan, that when you look at a PE scan, goes from the bottom up, as opposed to top down.
That where PEs are more prevalent at the bottom?
Okay, but so what? Why go from the bottom up?
Older scanners like maybe slower or something?
What?
Were they like slower time to like scan them?
So what are you getting at?
Maybe the contrast.
Like
What?
best captured at the bases. Like your best images are going to be at the bases.
Why?
Because of the contrast timing.
No, it's not.
Motion?
Hmm?
Is it respiratory motion?
Yeah. So with the older scanners, it took longer. Sometimes before we got to 16 slice scanners, it could take 20 seconds to scan through the chest. So the patient would have to hold their breath for the whole scan. Okay. And so since most PEs go to the bottom of the lungs, you would want those images to be without respiratory artifact, without breathing. So if the patient started breathing at the top of the scan, that was okay. So your PE protocols were set up to start scanning at the bottom and go from the bottom to the top. Now with the new scanners, you can scan through the whole lung in 2 seconds, right? It makes no difference whether you go from the top down or the bottom up. But that's why you will see that if protocols are carried over, you will see that when you look at a PE protocol, it goes from the bottom up as opposed to all your other chest CTs that go from the top down. Okay, and that's the reason for that. The best instruction, actually, when you're doing a CT for PE is not take a deep breath, but stop breathing. Don't breathe, stop breathing, or if the patient can't hold their breath, breathe very shallow. We'll get to why that is. Bolus tracking, this is how you ensure that your timing is correct. So region of interest, put over the vessel of interest. So if you're doing a PE scan, we put that over the pulmonary artery, a series of low-dose CTs at that one slice location, usually separated by about 5 seconds. And the software measures the attenuation inside your region of interest. Once it hits this particular threshold, that triggers the study to begin, resets the table, and the study starts. Depending on your scanner, there will be a delay between when you hit that trigger and when the scan starts because the table has to reposition. Sometimes that can be as long as 8 seconds, 9 seconds, sometimes 10 seconds. So you have to take that into account. So make sure that as you're structuring your protocols, you take that into account about how long is it going to take to reset the table, and that might determine where you set your threshold. So if it's going to take longer to reset the table, you're going to lower your threshold. If it's shorter with the new scanner, it resets very quickly and it scans very quickly. So one of the problems with the new scanner actually is it's scanning so fast that it might be scanning too early even after you hit the threshold. So at some places they've added it with these alpha scanners. They've actually added an additional delay to make sure because the scanners are so fast. Okay. So we've talked about PE, filling defect within the center of the vessel. Look for contrast going around it if you're within the smaller vessels. Peripheral opacity, right, usually a sign of an infarct. When you're looking at these CTs and you're trying to decide if it's an infarct versus consolidation versus atelectasis, what are the things that you would look at to try to make that differentiation? You see a peripheral opacity. Is it an infarct? Is it atelectasis? Is it consolidation? What do you do to decide that's an infarct?
Look for volume loss to exclude atelectasis.
Well, you can have atelectasis without much volume loss on CT. I mean, we always kind of see that. I mean, if you have lobar collapse, right, yeah, then you're going to have marked volume loss. Well, you look at the attenuation, right? If it's atelectasis, the lung will enhance, okay? If it's an infarct, the lung will not. The other thing that you want to look for is look at the vessels going towards it. Look to see if those vessels have thrombus in it, or if those vessels are decreased in attenuation compared to vessels elsewhere in that same location in the periphery of the lung, right? So these are the things that you want to do. Sometimes you can also have a reverse halo sign within an infarct, so we can see that also, okay? So PE, of course, very good for the CT is very good for PE, so you follow this here. Often these go to branch points, so you can see that it kind of bridges. The clot is like a string of spaghetti. It gets stuck at a branch point, so it will bridge. When we get to it right there, you'll see like it'll get caught at a branching point, and it bridges along both sides of the vessel. That can increase your confidence that what you see really is a pulmonary embolism, if you can see that this is lodging at a branch point like that, right? So that's your typical appearance of a pulmonary embolism. And you see contrast around it, so central filling defect, and you can see contrast around it. Also, the density helps. Real PEs tend to be low in attenuation as opposed to flow artifacts, which are somewhat more diffuse in attenuation. The edges aren't as sharp. So they're not as low in attenuation as PEs, and the edges are not as sharp as you see with PEs. Many times you see a scan like this in the ER, right? And the line you put in the dictation is suboptimal study because of, well, you guys always do this, because of what? Poor contrast timing, right? How many times have you seen that in a report? Yes? No? Yes? Is this poor contrast timing? Is that the reason it's a bad scan? Is that the case here? Yes or no? Is this poor contrast timing?
No.
How do you know?
Because there's like contrast that opacifies the aorta.
There's contrast in the aorta, right? So does that mean that it was scanned too early?
No.
No, it couldn't be scanned too early. The contrast is in the aorta. So it was scanned too late, right? Because the contrast is now in the aorta. We missed it. Bad timing. Is that the answer?
But isn't there like also contrast in the like right ventricle, right atrium?
Okay, but there's contrast in the SVC, right? And you're right. There's also contrast in the right-sided chamber here. Not so much here, but they're lower down. But there's contrast in the SVC, right? So the contrast, you can think of the contrast as a snake. It has a head and a tail, right? It's a long column of contrast. So if you see one end of the contrast in the aorta and the other end of the contrast in the SVC, well, what's in between, right? The lungs and the pulmonary arteries. So it's not a problem with timing, right? So what is the problem? Why do we see this on PE scans if it's not a timing issue?
They could have taken a deep breath during the scan.
So what do we call that? There's a term for that.
I don't know the term, but basically.
Well, it's abbreviated TIC, TIC. Transient interruption of contrast. So what does that do? Also, Valsalva can also do that. So what happens if a patient takes a deep breath right before you start to? So the contrast goes in, we're ready to scan. Either the instructions weren't set right, or the patient takes a deep breath right before the scan. What goes wrong?
So IVC mix.
Yeah.
Does the blood from the IVC go?
Yeah, you have the IVC blood. When a patient takes in a deep breath, it draws in blood from the inferior vena cava. The blood in the inferior vena cava is not opacified, right? Because the contrast is coming in from the top. So the unopacified blood goes into the right-sided chambers, mixes and dilutes out the contrast that you have. So in between your contrast column, you will have this blood that does not have contrast in it. That's called transient interruption of contrast. Okay. So here's examples of what happens. On expiration, you don't have undiluted contrast coming in from the IVC, but on inspiration you do, and that will dilute out your contrast. Okay. So if you do coronal reconstructions, you can see that there will be areas of the lung where you have very good contrast, and then once you get into the main pulmonary arteries, which is the area that you're interested in, all of a sudden all your contrast is washed out because of that transient interruption of contrast. Sometimes we'll get a CT scan that is really good, right? It almost looks like the contrast sticks to the right ventricle, the right atrium, and sticks to the pulmonary arteries. So when you get a really good CT scan, what do you think about?
You have like poor heart function.
Yeah, poor cardiac function, because that decreases the cardiac output, and that delays the transit time of contrast. So that will keep the contrast in the right side of the heart. And sometimes it can actually work against you, because sometimes, there will be very good contrast within the proximal pulmonary arteries, but not in the distal, or very good contrast within the heart and not within the pulmonary arteries, because that circulation time has been delayed from the poor cardiac function. All right, so you're all used to looking at these. At this point, in addition to the PE, the thing you want to mention is what?
Right heart strain.
Yeah, so the right heart strain. So when we see that the right-sided chambers are dilated compared to the left, that's important prognostic information, right? So they need to be more aggressive in terms of treating the pulmonary embolism when you have dilatation of the right heart chambers compared to the left. So if there's shift of the septum, if the diameter of the right ventricle is greater than the left ventricle, you can compare at the level of the valves. At the level of the mitral valve, it should be about the same as the tricuspid valve. But if the right ventricle is bigger than the left ventricle, then we worry about right heart strain. And actually, that the higher that ratio, the worse the prognosis, right? So the cause of death, usually from PE, is acute cor pulmonale. It's right heart strain. Okay. All right, so let's move on to dual energy. So you've all had physics, so you're all familiar with this. Is that what leads to absorption of the X-ray? It's kind of good and bad. It's good because this is what we look for to attenuate the X-ray beam, the photoelectric effect. The bad part of it is, of course, it means the energy was absorbed, right, within the patient. Okay. But that photoelectric effect is what leads to absorption of the X-ray, and that's also what causes ionizing radiation. So if we look at the X-ray energies right in here, which is the range of the energies that we use for imaging, that's very close to the K edge of iodine. And so you can see that the absorption of iodine compared to, let's say, water and calcium, right? This has the most dramatic change. So this is why iodine is very good as a contrast when we're using it for radiology. And so, again, if you're using spectral CT and you're looking for contrast, you can see the attenuation changes of iodine compared to calcium and water, right? There is some for calcium, pretty much none for water, but it's the most dramatic for iodine. As you go to lower energies, the attenuation of the iodine really increases a lot. And that's very useful when we're doing this dual energy CT. So what does that mean? It means that at lower KVs, the iodine gets brighter. So these are virtual reconstructions, from a multi-energy CT scan. And we can do these virtual reconstructions as we lower the KVs, the iodine gets much brighter. So you can turn any CT scan into a CT angio, regardless of how bad the timing may have been. And so if we look at what happens at low energy versus high energy, so if we look at water, the attenuation of water at 140 kV, about 0. At 80 kV, it's the same thing. It's about 0. If you look at soft tissue with iodine in it, if you get in contrast to the liver, or if you're looking for a subtle bleed or something like that, what happens there? Well, at 140 kV, you can see the attenuation in this particular example is a little bit below 100. But over here at the lower kV, at 80 kV, it's up near 140. Okay, so what the software will do is it will look at the attenuation of each pixel at low energy and at high energy, and then it will look to see how it changes. And depending on how it changes, the software can decide, what is within that pixel. Is there iodine in that pixel? Is there calcium within that pixel? And that's called material decomposition. Actually, with the alpha scanner, it's a little bit different. It actually counts the energy of the different photons going through the different areas, and then it uses that to differentiate what the different materials are. So that we get the X-ray beam firing these electrons at your target, and that's what gives us the X-ray beam. So the KVP settings available for CT scanners. So you can't just sit there. If you tell the tech and say, I want to scan this patient. First of all, why do we call it KVP and not KV?
Energy.
Yeah. So the P is the peak energy. So that means the energy is not above that. But there are all kinds of energies at that level and below. Okay. But it's not an arbitrary number. You can't tell the tech, I want to scan this patient at 82 kVp, right? There are particular settings on your CT machine. Anybody know what those settings are? Give me a few numbers. On the new scanner, you have that, yeah. On the old scanner. But so the standard settings were 80, 100, 120, On the alpha scanner, we have these settings. We have 70, 90, 120, 140. So these are set settings for every protocol. So when you set your protocols, you have to decide what KV setting you're going to use for that particular scanner. An estimate of the average energy, though, within the X-ray beam, right? So if I have a KVP setting of 140, what's the average energy? It's about half of that, right? So it's about 70. So when you look at the spread here, so if you have a KVP of 80, this is what the energy spread is within that X-ray beam, and you'll see that the peak is somewhere around a half of it. And then at 140, this is what the spread is, and the peaks are somewhere near about 1/2 of that. So really, there are multiple energies that are within this X-ray, within the X-ray beam. Most of the energies are about, or most of the photons are halfway in energy to your KVP. Okay, so the X-ray beam is polychromatic, not monochromatic, meaning that it has multiple different energies. So dual energy, dual spectral, spectral CT, this takes advantage of the different energies. It's a very old way of trying to do this would be to scan the patient twice, once with a low KV, once with a high KV, but of course you get misregistration artifacts with that. It's hard to keep the patient in the exact same position if you're going to bother to scan them twice. With the GE scanner, it's dual source, meaning that, with the G scanner uses fast KV switching. So the G scanner has one X-ray tube, and it switches very quickly between low energy and high energy, so you don't get misregistration of the position of the anatomy. With the alpha scanner, it's a dual source scanner. So you have two X-ray tubes, 90 degrees to each other. So with a dual source scanner, you can do spectral CT or dual source CT by having each tube scan at a different energy. Is that what we do on the alpha scanner? Yeah, you don't have to do that on the alpha scanner because it's an actual photon counting scanner. So it actually counts, it can count the energy of the photons. So both X-ray tubes can be at the same energy, and I think in most of our protocols they are, that the X-ray tubes are at the same energy, because it can count the photons and bin them into different energies, you get that dual spectral advantage because it's counting the energies of the photons. Okay. You can, if you want, if you want to, let's say, what protocol might you be doing where you really need to have really accurate dual source or really accurate information between different energies, where you would want to set the energies different on your dual source alpha, photon counting scanner. What kind of protocol might that be? Where it's very important to get that different spectral information. Not in chest imaging.
Like post-thrombectomy for the head?
Hmm?
Like post-thrombectomy for the
Characterizing renal stones. So if you want to characterize, let's say for gout, or characterizing the renal stones, composition of renal stones, where it's very important to get those different energies, and that will optimize it. It optimizes it then if you have the two X-ray tubes at different energies.
Do we do that in our protocol?
I don't know, because I don't do those. I don't do those, so ask. It's a good question. But, for chest and for everything else, we don't have to, because it's photon counting. Of course, on the GE scanner, you do have to have the KV switching, right? But on the alpha scanner, you don't have to have the tubes at different energies to be able to get that spectral energy, okay? And then so that's our photon counting scanner. There's dual layer, so where the different layers of the detectors are sensitive to the different energies. So this technology is also available out there. The advantage is, of course, in your post-processing, right? You can go back and change your KVs, and when you do that, you can make the iodine brighter. And so it's very good for looking for iodine. So here's an example. These are virtual reconstructions at 120 keV, not very good contrast, dial it down to 70. Now it looks really nice. So this can save a bad PE study if you happen to use a dual energy protocol, right? It can save your PE study. So by default, all the scans on the alpha scanner have this capability because it's photon counting, okay? You can get virtual non-contrast images, right? This is this was actually one acquisition, post-contrast, but with material decomposition, you identify the iodine and just post-process it, subtract it out from the image, you have a virtual non-contrast image, right? We can do that. Iodine suppressed imaging, that's what virtual non-contrast is. This was a case from over the weekend when I was here, so, on the photon counting scanner. Stone or contrast, you have something here, you have something here, right? Is it stone or contrast? Which is which? Well, just look at your virtual non-contrast image. That's a stone. That's contrast. Amazing, right? So this is available now on your alpha scanner. We can do this. With lower doses, you can get good angios with 20 cc's of contrast. That's what a conventional CT would look like. Horrible. But with your monochromatic reconstruction, now you get a pretty decent angio, which is 20 cc's of contrast. This particular patient, the IV leaked, and we got terrible PE scan. So the IV leaked right at the most critical portion, right? Well, save the day with dual energy. See what it looks like at the lower KV. Now you get a decent CT scan here. Okay. So in this particular case, looks like you're looking here, left pulmonary artery. Contrast is not very good. Are those clots, right, in the left pulmonary artery? Are we going there? Are those clots? Well, we'll dial it down, 60 keV, and now we can see a little bit clearer that those are real clots within the pulmonary artery. Okay, so this is available for you to use, right? There it is there at 60 keV. That's what it looks like at 120. I mean, you probably still call it here, but now you can be much more confident of calling it there, okay? So here it is on some reconstructions to show you what that looks like. It's easier. You can do iodine maps, perfusion, right? So by identifying the iodine, you get these images where it shows you the perfusion, and you can see there's a perfusion defect here. Of course, you can do it in color. Whoever decided to, add color to these things, it's really good marketing ploy. So you can see these areas here. Right? There's a little bit of a perfusion defect there. There's a clot down there. Okay, shows that perfusion defect. Another nice example. So this area here is an area of infarct because of a clot, and you can see the perfusion defect very nicely there. To get rid of beam hardening, so with metal and all that stuff, you can get rid of beam hardening artifact by, in your virtual reconstructions, by increasing the KEV. That can get rid of the beam hardening. Okay. So here's an example where if you only had one scan, is this thrombus or is that just delayed filling? Well, when you dial down the KEV on your virtual reconstruction, you can see that the filling defect is not there. So there's iodine in this, right? So that's just a paucity of iodine. That is not a thrombus. And then here's a delayed CT just to prove it. Okay. So these are all applications of this. So let's move on to discuss pulmonary hypertension. So definition is sustained elevation of pulmonary artery pressure greater than 20 millimeters at rest. The term pulmonary arterial hypertension means that you have elevated precapillary pulmonary resistance with normal pulmonary venous wedge pressure. So the pulmonary venous wedge pressure is normal. This is the Dana point classification of the different classification scheme for pulmonary hypertension. You don't have to know all these guys, but it is fair game on exams for you to know what these groups are and what the difference is between the groups in terms of classification of these causes of pulmonary hypertension. So group 1 is pulmonary arterial hypertension. This can be idiopathic pulmonary hypertension, congenital heart disease, portal pulmonary hypertension. And then there's this group 1 prime, pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis, which we'll talk about later. Group 2 is pulmonary hypertension from left heart disease. So these will have elevated pulmonary venous wedge pressures. Most commonly left ventricular failure, chronic left ventricular failure, mitral stenosis. Group 3 is from lung disease or hypoxemia. Group 4 is pulmonary hypertension from thromboembolic disease, CTEPH, chronic thromboembolic pulmonary hypertension. So that is group 4. And then group 5 is just the garbage category, multifactorial mechanism. So, not sure what exactly the cause is, but that's group 5. So you have to be familiar. It can be an exam question, in terms of the different groups of pulmonary hypertension. What happens with pulmonary hypertension is the patient develops intimal proliferation and medial hypertrophy, and that increases the pulmonary vascular resistance. As that starts to occur, then the pulmonary hypertension gets worse, and then you get into this feedback loop where then you get more hypertrophy. So you can get this vicious cycle where once the patient starts to develop pulmonary hypertension, the pulmonary hypertension gets worse. In terms of etiologies, this can also be broken up into precapillary and postcapillary causes of pulmonary hypertension. Precapillary can be increased flow through pulmonary vessels, like with left to right shunts, things that decrease the cross-sectional area of pulmonary vessels or obstruct the pulmonary vessels, all these things that I've listed here. Lung disease also can do that. And then there's postcapillary, and these are things that increase pulmonary vascular, that increase resistance due to the pulmonary venous hypertension. And the most common things in this group are chronic left ventricular failure and mitral stenosis. The workup, echocardiography. So if we suspect pulmonary hypertension on imaging, the first test we recommend is echo. So how does echo diagnose pulmonary hypertension? Oh, it's time for a standing 8 count over there. TKO. How does echo diagnose pulmonary hypertension?
Doesn't measure the velocity
Of what?
The blood flow through the mitral valve?
No. Has nothing to do with mitral valve. Remember, you guys are all recommending echo we think there's a dilated pulmonary artery, 3.2, recommend echocardiography. So they measure the velocity of tricuspid regurg. Okay. The peak velocity of tricuspid regurg is related to the gradient between the right atrium and the right ventricle. The pressures in the right atrium are very low. If the tricuspid regurg velocity is very high, then the pressures in the right ventricle are high. So the number of the tricuspid regurg, the peak velocity tells them the pressure in the right ventricle, then they will assume that is the pressure in the pulmonary artery. Okay, so that's how they give you an estimate of pulmonary hypertension. The first test is echo. To rule out chronic thromboembolic disease, if that's a consideration, perfusion scan. If the perfusion scan is normal, the patient does not have chronic thromboembolic disease. To rule out other causes, if we're looking for lung disease or other things, you might even, rule out chronic thromboembolic disease, CT, PE protocol, right? Look at the pulmonary arteries. And then if we still suspect pulmonary hypertension, right heart catheterization, where they actually directly measure the pressures to confirm. And then they'll also give vasodilators to see what they can measure the pulmonary vascular resistance also. And then if you want to look at right ventricular function, the best way to non-invasively evaluate right ventricular function is with MRI. All right. Plain film findings, big right-sided chambers, dilated pulmonary arteries, central enlargement of pulmonary arteries. If it's from venous obstruction like mitral stenosis, you might see evidence of pulmonary venous hypertension also on your chest radiograph. So what do we look for on the chest radiograph? If there's no lung disease and you have very big central pulmonary arteries, these are the things you consider: Eisenmenger's, chronic PE, idiopathic. If there is lung disease, well, what is the lung disease? Emphysema is the most common cause of pulmonary hypertension in the United States. Fibrotic lung disease, if you see evidence of fibrosis. If there's evidence of pulmonary venous hypertension, is the left ventricle big? Is it chronic left ventricular failure? Are there signs of left atrial enlargement? Then it could be mitral stenosis, right? So those are the things that you look for on your chest radiograph, if we have that. So this particular patient has very large central pulmonary arteries, so we're thinking about pulmonary hypertension. What finding here on the CT scan is associated with long-standing pulmonary hypertension besides the big pulmonary arteries?
Emphysema.
The emphysema is the cause. So this patient, the cause, that's the answer to the second question. The cause is emphysema. But what's the finding that tells you the patient has long-standing pulmonary hypertension?
Calcification.
There's calcification of the pulmonary arteries. See that? So calcification of the pulmonary artery, you can actually see it on the plain film. There's calcification of the pulmonary artery here. Okay. So that's a sign of long-standing pulmonary hypertension if you see calcification along the pulmonary artery wall. The findings on CT associated with pulmonary hypertension. What do we look for? Well, on this image, you got what? Dilated main pulmonary artery. It should be the same diameter of the aorta. So 3 centimeters is a good number. Once it gets greater than 3 centimeters, you start worrying about it. I really start to worry when it gets to 3.5 or greater. Remember that, there's the specificity there. So if it's 3.1, 3.2, maybe not so much, but once you get to 3.5, then you start to get really worried about it. So dilatation of the main pulmonary artery. What's the arrow pointing to? Yeah, right ventricular hypertrophy, and then we have dilated right-sided chambers, dilated right atrium, right ventricle. On the last image, what are the arrows pointing out? What is the sign there? So that's called pruning of the pulmonary arteries, where the central pulmonary arteries are big, but the peripheral pulmonary arteries are smaller, out of proportion to the size of the central pulmonary arteries. That's pruning of the pulmonary arteries. MRI findings associated with right ventricular pressure overload. Well, here, this is pretty basic. So what are the findings there that tell you that there's pressure overload of the right ventricle? Yeah, so the RV is dilated, right? So the RV is dilated. Also here you can see there's pulmonary regurg. Okay, so when pulmonary artery pressures are high, you can also see pulmonary regurg, right? On this image, after contrast, what is the finding of elevated right heart pressure on post-contrast MR?
Is it like flattening of the septum?
Well, that's not, the flattening of the septum you see here too, right? That's the dilated right ventricle. But what about the contrast? Is there abnormal enhancement? There is. Where is it? It's right here at the hinge points. So at the insertion of the right ventricle on the interventricular septum, you apparently get this added strain, and you'll develop a little bit of fibrosis there, and you get these areas of abnormal enhancement. There's another disease that also gives you enhancement at the hinge points, although it looks completely different than this in terms of the other characteristics. What disease also gives you enhancement at the hinge points? Cardiac disease. Yeah, hypertrophic cardiomyopathy. But of course, that's not going to give you a dilated right ventricle. You're going to look for evidence of left ventricular hypertrophy with that. But that can also give you enhancement at the hinge points. But this you can't see with pulmonary, with right ventricular strain for pulmonary hypertension. Right ventricular pressure overload, dilated right ventricle, hypertrophied right ventricle, the so-called D-shaped left ventricle, because it's compressing, it's pushing on the interventricular septum and flattening it, gives you a D-shaped left ventricle. So when that septum is deviated towards the left side or flat, deviated towards the left side throughout the cardiac cycle, that tells you that the right heart pressures are elevated throughout the cardiac cycle. Okay. Eisenmenger's. If this gives you the biggest central pulmonary arteries you see, so if you see an adult with really big central pulmonary arteries, think about underlying congenital heart disease, where they had a left to right shunt that is converted right to left, bidirectional or converted right to left. That gives you the biggest central pulmonary arteries that you actually see. So it could be PDA, VSD, sometimes ASD, although not as common. So huge central pulmonary arteries in an adult. Think about Eisenmenger's syndrome. Is there an underlying congenital heart? This was an ASD in this patient. Think, is there an underlying congenital heart disease that has been missed? That is one part of the differential that you have to consider. And when you have long-standing tremendous pulmonary hypertension, you can develop atherosclerotic disease, actually, or in situ thrombus within the pulmonary arteries. One, atherosclerotic disease from the high pressures. Two, in situ thrombus because of the low flow, the stagnant flow within the pulmonary arteries. So that can also occur in addition to the calcifications. Now, what do we see here? Well, what's abnormal there? There's this filling defect, right, along the periphery of the vessel. So that's a sign of thickening of the vessel, eccentric filling defect, chronic thromboembolic disease. Right ventricle is also dilated in this patient. So chronic thromboembolic disease, in most cases, these acute emboli, they will resolve. But if they start to get incorporated into the vessel wall and you start to develop fibrosis there, then you have chronic thromboembolic disease. This can also affect the smaller vessels, leading to obstruction of these small vessels. So the things that we look for, you look for eccentric filling defects, you look for webs. These webs represent incompletely recanalized vessels, webs within the pulmonary arteries, another sign of chronic thromboembolic disease. We covered this before, eccentric filling defect here in the right pulmonary artery. What do we see on the lung windows? Well, what do we call this? What's abnormal, the ground glass or the lucent area? The lucent area. So this is
Oligemia.
Yeah, it's oligemia. This is mosaic perfusion, right, from chronic thromboembolic disease. So you can see that also with chronic thromboembolic disease. These areas of mosaic perfusion where you have decreased perfusion, it looks more lucid, but the blood vessels are also decreased in caliber. How do we differentiate this from air trapping? Well, air trapping breaks down into secondary pulmonary lobules. This tends to be a little bit more diffuse in terms of its distribution. This person has chronic thromboembolic disease. The finding on the second image. What's the finding on the second image? What are all these guys?
Collateral.
What collaterals? What vessels are these? Those are bronchial arteries. So with chronic thromboembolic disease, you can also develop collateralization as bronchial arteries you'll get these tortuous dilated bronchial arteries as they'll try to provide blood flow to the lungs. Okay, so dilated bronchial arteries can be associated with chronic thromboembolic disease. The parasite associated with pulmonary hypertension is schistosomiasis, right? That can also give you pulmonary hypertension, right? Idiopathic pulmonary hypertension, big central pulmonary arteries. This is the diagnosis of exclusion, so you have to rule out everything else. Usually younger females, progressive shortness of breath can be associated with Raynaud's. It's a diagnosis of exclusion. Radiograph, just big central pulmonary arteries. There's nothing really specific about the appearance of this on the radiograph. This patient also has huge dilated central pulmonary arteries. What's this person's underlying disease? COPD, right. You have hyperinflation, and you have all this paucity of vascularity up there, flat diaphragms. Very common cause of pulmonary hypertension, COPD, big central pulmonary arteries. You can see COPD, dilated right ventricle, hypertrophy, dilated right atrium. You'll see this a lot, okay? Here, this patient also has a big central pulmonary artery, but you can't tell me what this patient's underlying disease is that's resulted in pulmonary hypertension. What's the underlying disease? There is pulmonary venous hypertension, right? So pulmonary venous hypertension, pulmonary artery hypertension. What chamber's enlarged? The left. The bulge is here, left atrium. So the left atrium is enlarged. So what's the underlying disease?
Mitral regurg.
Not regurg, but stenosis, right? Mitral stenosis is more likely to cause pulmonary hypertension than mitral regurg, but this is the appearance of mitral stenosis. Pulmonary venous hypertension, pulmonary artery hypertension, big left atrium. So if we see that, that's rheumatic heart disease, mitral stenosis, 99% of the time. The other 1% is what? If you have this configuration, 99% rheumatic heart disease with mitral stenosis, 1% or even less is, that might be an exam question actually, besides mitral stenosis. What's the answer?
And would it be mitral regurg?
No.
Oh.
Still no.
Is that
Left atrial myxoma. Same mechanism for obstruction of the mitral valve. Okay? All right. So we've covered, mitral stenosis before. So here on the CT, you can see the thickened mitral valve and the big left atrium. So, we won't go through all of that. This patient has pulmonary hypertension, normal pulmonary capillary wedge pressure, which is a big clue that that's a typical something that they tell you on the exam. Interstitial edema, you can see the interlobular septal thickening. You can see the dilated right-sided chambers because of the pulmonary hypertension. Normal size left atrium and left ventricle. So, they might not give you all this information, but if there's evidence of interstitial edema with pulmonary hypertension with normal left-sided chambers, right? The disease that you're supposed to consider is, remember, in most cases, if there's interstitial edema, there's elevated pulmonary capillary wedge pressure, there's left heart disease, so mitral stenosis, chronic left ventricular failure. The left-sided chambers will not be normal. But if the left-sided chambers are normal and it looks like you have interstitial edema with pulmonary hypertension, what's the disease? Rare disease. This is, it's that spectrum, pulmonary veno-occlusive disease, right? So pulmonary veno-occlusive disease, this is fibrosis of the small pulmonary veins. Most patients are young. There can be secondary causes also, like pregnancy, bone marrow transplant, chemo, etc. So this will obstruct the small pulmonary veins. So this then results in interstitial edema, but the left-sided chambers are normal. Your pulmonary capillary wedge pressure, because your left-sided chambers are normal, will be normal, even though it looks like the patient has interstitial edema. And they will have signs of pulmonary hypertension with a big central pulmonary artery. So interlobular septal thickening, signs of interstitial edema with normal left-sided chambers with elevated pulmonary artery pressure. One of the criteria for diagnosis of this condition is that the pulmonary venous wedge pressure is normal in these patients. Right? So that's pulmonary veno-occlusive disease. All right. So they can have interstitial edema, even pleural effusion in this case, some big lymph nodes from the interstitial edema. This disease, which can give you centrilobular ground glass opacities with pulmonary artery hypertension and normal pulmonary capillary wedge pressure with centrilobular ground glass nodules. What is this disease? This is pulmonary, right. This is pulmonary capillary hemangiomatosis, proliferation of the pulmonary capillaries. Another rare disease, this also results in pulmonary artery hypertension with normal pulmonary capillary wedge pressure. So you might see big pulmonary arteries, but the centrilobular ground glass opacities represents areas of petechial bleeding because of the proliferation of the pulmonary capillaries. So centrilobular areas of ground glass associated with pulmonary artery hypertension. Now, having said that, this pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis are now considered the same disease, just different phenotypic variants of the same underlying disease. It's a mutation in this particular gene that disrupts the pulmonary microvasculature. And so that leads to venous capillary remodeling. Sometimes patients have overlapping of both, but it's rare, it's genetic, it's in younger patients. What you need to know about this is that use of pulmonary vasodilators, which are used to treat primary or idiopathic pulmonary hypertension, are contraindicated because they can kill the patient. Okay, so you don't want to give these patients vasodilators, even if, I guess, so you have to be very careful of that. That is an exam question that they might ask you about. So that's why it's important to think about this diagnosis that, vasodilators are contraindicated in these patients. Okay. All right, so that is our discussion. We'll do the quiz next time. Any questions? Okay.